listening to Dr. Su's presentation on MI's TLIF, fantastic presentation, and hopefully I'll do some justice to this approach. I'm here with Pericles. He's an orthopedic spine fellow, and I know you went through his technique, and this will be a bit of a variation on this. And if you can show the AP view on the fluoro. So what I did was mark the skin based on some AP views. Not that one, the other one. Yeah, image number 2. So you just take a K-wire, and you want to start outside the pedicle, so about 1 centimeter outside the pedicle. So I marked the pedicle. You can see where I marked the line on the K-wire here. And about 1 centimeter or so beyond the lateral margins of the pedicle. So you do that bilaterally. And just long lines on the skin, and that'll be where your skin incisions will be. You're going to make 2 perimedian skin incisions. Then you go to lateral, and I have a 22-gauge spinal needle here. And can you go to the last picture, picture 6? Oh, no. Oh, you didn't save it. Okay, we need to take a picture. Oh. It does not project well. Do you see the needle? So the needle is pointed toward the disc. You want to be orthogonal to the disc. Right there. That's good. And that's where you're going to center your skin incision for your tubular retractor placement. So the workflow for MI's TLIF actually is fairly varied. Some people put the K-wires in first, cannulate the pedicles, then do the TLIF. I'm going to change it up a little. I'm going to do the TLIF first, then we'll put the screws in. So the order doesn't matter. You just want to pick an order and be consistent with it. Some people think that you need to have screws in to do the inner body work, and it's absolutely not the case for the most part. You could do the inner body work first, so that's what we'll do here. So this 22-gauge spinal needle is pointing to the disc orthogonally, and it's along the parallel perimedian lines we drew based on the AP views. And we're just going to center a 1-inch incision here.
You want it like this?
Up and down.
Up and down.
A little bit bigger than that. So we need about 1 inch for the tubular retractor. I'm just going to make it a little bit bigger because that's like half an inch here, just to get to the pedicle margins here. And it usually winds up being about 1 inch or so. And I'm just going to cut through it here. I usually just bovie through the fascia, but you want to cut through the fascia because it'll make rod passage easier. So now put my finger down, and in most cases you can actually feel the facet joint, so you have a good idea of where you are. And I could feel the facet joint here if you want to take a feel here.
Yes.
And you have the initial dilator. So I'm going to put my finger down. We'll put this dilator. You should always fluoro, particularly when you're starting off. See, I'm right on the facet joint. I'm going to slide down just a little, picture again, and I'll slide up the facet joint, like that picture. Oh, no, that's okay. So I'm going to just sequentially dilate. You don't have to take a picture every time. Just keep your hand in the position and keep your eye on the trajectory here. I think one more. And then tubular retractor-wise, these dilators are demarcated for the length. About an 80 millimeter length is what we need here. Oh, okay.
What you want?
That tubular retractor there. Thank you. So this is already kind of set up for us. This is a spotlight retractor, so you can see that the light is built in. I don't know if you can see that on the inner side of the tube. So it's very convenient in that regards. So I'm just going to slide it right over our tube here. And so a twisting motion is usually best. So this is, I think, a little long, but we can make it work. We could have probably used a shorter tube, but I think that would be fine. Can we slide this down a little? Brandon, do you think we could slide this down just a little? It's going to be hard for us to get that angle here. So, placement of this tubular retractor is actually, slide to the feet if you can.
It doesn't connect here.
Okay, great. And let me go to this.
Yeah, no.
Okay, great. Great, so I'm just going to tighten this down provisionally. And then we'll get a provisional positioning here in X-ray. It's a little low, but it's easy to adjust. picture? Okay, so we're centered right over the disc space. Again, this tube's a little long. We could have used something smaller, but we'll just go with it. And so, you know, you want to be orthogonal disc space, just like on a lateral fluoro. You can get an AP. If you're just starting off doing MIS TLIFs, I would get an AP just to make sure you're where you think you are. And that's the big thing about minimally invasive surgery. You should not do the procedure unless you have good AP and lateral views, and we've already checked that. If you don't have good views, you can't do the case, because with MIS, you don't see the surrounding anatomy very well, so you're dependent on fluoroscopic guidance. So without good views, you really can't do a good operation. So we'll show you a picture down here through the tube. Now, what you often see is a little bit of muscle at the bottom of a tubular retractor.
And then on the other side, he's going to adjust it.
Okay. So here we go here. Yeah. Yeah, we're going to have to tilt it probably 30, 40 degrees. Not bad, though. Okay. So can we slide the fluoro north for a second? And then we'll take a bovie here. And usually, having an extended tip is ideal. We don't not have an extended tip here on this bovie. And so that's going to be a little, oh, do you have one? Oh, great. I was going to say, with a long tube like we have, I was going to say it's going to be a little bit of a challenge, but we do have a longer bovie tip here. Now, no, it's too late now. I mean, ideally, you should probably use a shorter tube here, but we'll just make it work. We'll make it a little harder on ourselves, but it's manageable. So I'm just going to, so you can see here, I'll get out of the way in a second, I'm just boving the tissue off the facet joint. And so you should be able to see the majority of the facet joint in an ideal position. And this looks pretty good here. I'll just gonna get rid of a little bit of muscle at the bottom. So compared to like an open MIS or an open TLIF where you're stripping the muscles off the bone, this is a lot less tissue disruption. I'll tell you how much muscle we're gonna take out of here. This is about it. Here you can see how much tissue there is at the bottom of this. Very little. Okay, I know. Oh, I'm just kind of getting it all set up. So this is about the amount of muscle we removed. Actually, that's pretty neat. Black smoke. Okay. So when I look at this position, we're just a little bit medial. So let me get the smoke out of the way. You can see what I see. So orientation-wise, here's the facet joint. You can see the facet line there. Here's a lamina. There's a lamina. So it's a little bit medial because I need to see a little bit more of the superior articulating facet. We have a good view of the inferior articulating facet, but not a great view of the posterior. Now that's easy to change. You take your last dilator, and I'm just going to tilt it a little lateral. And I'll lock it in a position, and then we'll get another picture here. No, this one, thank you. So I made it harder on them. But we're going to see more of the joint now. Borrow that, thank you. That's great. So let me get a little bit more of the tissue out of the way, but we'll see more of that superior articulating facet. So we're going to see more of that facet capsule and complex here. So I see the pars interarticularis. So here's a facet joint complex. My sucker's right on it. Right? It's great. And here's the pars interarticularis. I'm falling off the pars. There it is. We had a great view. This is a perfect view. And here's a lamina here. Right here's a lamina. And a little bit of soft tissue on it. If you could pan out, I want to show you how much tissue I removed at the bottom of the tube.
You have to put it further here.
Yeah, let me put it over there. That's about the amount of tissue we removed. Very little here. Like 3 or 4 millimeters of muscle at the bottom of the tube. And so the amount of muscular disruption is minimized. Now, the next step is you can either use an osteotome, or in this case, we're going to use a drill. We're going to drill a laminotomy. Where's a pedal here?
That's this one?
Oh, you mind stepping on it here? So I'm just going to drill a trough. Go ahead, if you don't mind.
I don't think this is the right.
Oh,
Where's the pedal for the drill?
oh, yeah, where's the drill pedal? Oh, thank you. Thanks a lot. I'm going to drill a little laminotomy here. Now, so this is a straight drill, and often for an MIS case, I'll use a curved drill shaft so I can see the tip. Right now, I can't see the tip very well. So, I'm drilling mostly by feel, which is a little bit less safe than using a curved tip where you can see a curved drill shaft so you can see where the tip of the drill is. So here's a laminotomy I'm creating here. I'll show you a picture in a second. So you're just drilling the inferior lamina until the ligamentum flavum is in view. Yeah, I just want to drill enough to see. So can you angle it a little bit more medially, the camera? Pull it out and medialize it. So. No, you're right there, right? Oh, no. In the tube, a little bit more meat. Oh, that's great, right?
Yeah, they have to.
Right there. You can see my laminotomy defect right there, the white. So I'm almost through to the ligamentum flavum, right? So I drilled through the outer cortex, the cancellous bone. Now I'm in the inner cortical bone. So almost to the ligamentum flavum here. Okay, I can see the ligamentum flavum now. Okay. Okay. So I don't know if you can see that, but that's soft at the bottom, so there's ligamentum flavum there. So I've made my laminotomy. I'm going to make a transverse cut into the pars. Show you relevant anatomy in a second. So this is almost through. Okay. Once you drill through the pars, this will disarticulate the inferior facet, and I'm almost there. One or two areas. Okay. Okay. Can I get a little cob, please? Is there a cob or? Okay, I'm going to just put this cob here. And as you can see here, I've disarticulated the inferior facet. And I'll just need a Hartmann here. So this is just a classic TLIF. I'm going to remove this, and this can be saved as autograft bone. And this is the inferior articulating facet. You can see the smooth surface here. And there you go. And now you can see what's remaining. That is a superior articulating facet, that pink smooth surface. Here's a ligamentum flavum where my sucker's on. And here's where above the facet joint. This is the foramen right here. So now you have to remove the medial border of the remaining articular facet and the superior tip of it. I could use a drill to do that, and I'll speed things up. Okay, I have a kerosene. So I removed some of that bone now, and I probably drilled through a little bit of the Bigger kerosene. Like a 3. Do you have a... Let me try this. Oh. Oh, you have 2 2s. Okay. I think you skip a size, but... So this is just removing the tip of the remaining articulator facet, and that'll essentially unroof the lower part of the frame. And this is classic for TLIF again. And you'll see, well, I'll remove a little bit of the ligamentum. You'll see the thecal sac and then the disc space. So if you remove bone that's remaining here, the superior bone of the articulating facet that's remaining, the superior articulating facet, you'll get flush to the inferior pedicle. So I'll get flush to the thigh pedicle here. Again, I'm just removing the remaining articulating facet that's in my field of view here. Clogged here. Oops. Great. Let me see if I get. Is there another sucker there? This one's clogged.
Maybe this here.
Ah, thank you.
Yeah, I got it.
Thank you. Yeah, see the thecal sac here? And here's the disc. Again, once you actually position the tube correctly, right over the disc space, you don't have to move it typically. And you just have to remove the bone within the tubular retractor, and it'll take you right to the disc. So there's the annulus of the disc there. Oh, let me get out of the way. It's right there, that grayish. It looked more white earlier, but here, let me suck out the blood. But here's the annulus of the disc right there, right next to my sucker. Right there. So we have a clear, wide view here. And again, I just removed that remaining articulated facet bone, the superior medial aspect of it. Thecal sac I'm retracting is right here, underneath this ligamentum flavum. All right, can I have a blade? Okay, thank you. Ooh, it's a big blade. I would normally use a 15. This is a 10. The patient has a big disc space anyway, so I guess that's okay. You can see the blades in the disc space here.
Hey, Paul, in a case like that, would you normally look for the traversing nerve root, or would you be happy?
Yeah, it's right here. It's right underneath my sucker. Fortunately, there's a lot of room here. So, but I can see it. I don't know if it projects well. It's right underneath that ligamentum flavum.
Yeah, you can see
right
it.
there. Do you see that?
Yep. No, you can see it there.
So this is
right underneath.
I'm right on it. I'm right on it. I'm retracting it actually right there. And yeah, you gotta rotate the shaver. What is this? Is something smaller, or is this it? No, is this a shaver? Okay. Can you come take a picture? Let's just see where I am. I just, you don't always have to take a picture here, but it's, you know, we haven't taken a picture in a while. I just want to make sure. See, I'm right over this space here. You have and take another picture here. So I'm right in disc space. I'm just going to turn this because it's a huge disc space, as you can see. You got a bigger one now? 8. Yeah. But as long as you get the tubular retractor position well, you just remove all the bone, you know, within the retractor, and you're going to have a good working channel here, typically. Picture. You can see how big this disc is. That's an 8 millimeter. And so this is at least 12. Yeah, okay. And so, you know, if you have a fat disc like this, one, you might question why you're operating on it. But if you do, you want to fragment it with this rasper so disc will come out. Okay. Oh. Do you mind sliding down a little? Thank you. Can I have a Hartman? Thank you. So I'm just going to take some of this disc material out. There's a lot of disc that came out. Yeah, I'll take the Hartman. See in there, it's all disc. Hartman? Oh, not a Hartman. I know we've all done TLIFs before, and you know, an MI's TLIF is just basically an open TLIF. It's just you're working through a smaller working channel. And as long as you get familiar with or comfortable working through a smaller working channel like this, it's a very straightforward procedure. I'm going to enlarge my annular opening here. And I like the kerosene. And once I do this, it'll be easier to fit a cage in. That Hartman. So, do you have an upgoing Hartman, like one angled up? And, oh, no, it's just a kerosene. No? That's, yeah, but upward. That's fine. I don't think we have it. Hey, do you want me to use that disc removal tool or that? Yeah. Okay. So there's this, you know, taking out disc is just painful. It's just like, it just takes time. You need to really do a good job. So I would advocate you spend your time doing a good discectomy and end plate preparation. But it is tedious, particularly with this fat. So here's a tool that honestly I've never tried. I was just looking at it, and it's meant to like repair the end plate and remove tissue. So hopefully it's a good disc press tool. So let's try it here. Okay. So yeah, I'm using it. I'm right against the end plate, so I'm not sure it's supposed to. Okay, let's take a picture. Let's see what it looks like. And nothing's coming up on the catch basin. Okay. Oh, actually, one more picture. So I'm right against the end plate. I can feel it, and yeah, I guess a little bit. I'll take a picture. I'm on the bottom portion now. Picture. Okay, good. You can slide down. So hopefully this thing, it seems like it's working where I could scrape the end plate here. Hopefully I'm not violating them. Okay, yeah, looks like we got some disc there.
Not bad.
Yeah. So again, this is very tedious, but well worth the effort, right? If you don't get good end plate preparation, good discectomy, you're not going to get a good result. So even though it's going to take, feels like it takes forever sometimes, I would just keep doing a good job preparing your disc space. So there's our annulotomy and discectomy. Where's the cage? Oh, where's the trial? Can I get a trial? Is there a trial? Oh, yeah, let me just try it. Then I'll put that in. So I'm just going to trial this. This is a 12 by 7 millimeter trial. And again, normally I would retract the thecal sac, the traversing nerve root, but in this case, it's actually, there's a lot of room. And sometimes you see that with the TLIF where there's a lot of room where you don't have to retract the traversing nerve root very much. Picture. So I'm good. I'm in a disc space here. Okay, where's the graft inserter here? So this is a tool that I think is kind of neat. It's how, you know, not only is taking disc out very tedious, putting your graft in is tedious as well. So this is, if you can show this, this is filled with allograft bone or cellular allograft bone, Vivigen, and this is an applicator that could be put down a tube, and I suppose you could do this with an open case as well. But, so I'm going to push this into the disc space that was created, and this is not, I don't think it's radio opaque. So it's in the disc space, and now I'm going to inject the bone into the disc space. Again, I didn't do as good of a discectomy as maybe I would have for a live patient, but so there may not be as much room, but you can see I injected nearly the whole syringe full. That's 3 cc's, and we'll take a look down here. Oh, thank you. Oh, look, looks like it filled the disc space nicely. You can see the, actually, let me see if I can show it to you better. It looks like it's all in the disc space, and I can see it. I don't know, can you see it? Let me try to get it. Yeah, it's in the disc space. Looks like it's all contained there. So next is the expandable cage, which is this device. If you could pan out to show it, or where is the camera? Oh, okay. Right in front of me, okay. So here's an expandable cage. It has a large graft window, and this what does this expand to? Like 7 to 13? Okay, 13 million height expansion, which will be close. This space is probably about that much. Okay. Can you get a mallet here? X-ray. Okay. X-ray. All right, okay. X-ray. Okay, is that about, that looks about right. Okay, so I'm going to expand it now. And then we'll see what kind of expansion we get here. Yeah, I think X-ray. Great. Looks like it's contacting the end plate. So we maximally expand this. Actually, maybe I could do a little bit more. Okay, try that again. Okay, that's maximally expanded. Honestly, probably would need a slightly larger expandable cage, but this does fill it pretty nicely. You can see the expansion. What is it, 15 degrees or so? Yeah. Okay, do you want me to leave this in?
Unlock.
Okay. Yeah, I'll leave it in. I didn't know about retrieval later. Okay. Okay. If you're willing to grab it, that's fine with me.
It's tight.
It's tight.
Put the shirt back. Yeah.
Okay. Oh, I got it. Mechanism. Yeah, it's very stiff. Okay. All right. All right. So we have the cage in. Now we're going to, as you can see, so we did this without putting any of the K-wires or screws in. Now, that'll be our next step. Can we take a picture? And there's our cage deployed. Okay, for me, I don't use large incisions, so I don't really look at the anatomy. So I'm going to pull this tube out. So the TLIF is done. You can see the cage is within a disc space. And you could see the traversing nerve root right now. It's that structure right there, just medial to it. So I'm going to pull the tube. You can see all the muscle is going to come back. So this was minimally disruptive to the muscle. Now we'll put the cage in. I mean the screws. Okay. All right. I'll take that. And so there's different ways of doing this. Let me just bring this out. So this is, can I show this too? So this is a one-step screw. So it has a sharp K-wire. And it actually has aggressive screw tip. And so the K-wire is going to traverse the pedicle under fluoroscopic guidance. And once a K-wire has traversed the pedicle, this screw is going to be advanced with a K-wire. So it's a one-step system here. So just so you can see everything. So just to show you, I could lengthen or shorten the K-wire. So I'm going to lengthen the K-wire here. I don't know if you can see that. So you lengthen it as you traverse the pedicle. And then you could insert the screw over this K-wire. Okay, I have it projected out maybe like 3 or 4 millimeters right now. Okay. And so we're going to use this to anchor it in the pedicle. Picture. Oops, sorry. So I'm just going to feel down here. Just want to, again, I can't see anything, but you could actually palpate X-ray. Okay, looks better to me. X-ray? X-ray here? Okay. And can I get, where's the holder? I got it. Okay, can we go lateral, AP now? And yeah, thanks for saving that. Yeah, so that's not horrible. Can you do me a favor and tilt it down, just orbit it this way like 5 degrees. So we're going to look right, get a little better shot of the pedicle. That's good. Thank you. Yeah, still not the best picture. I can see where the pedicle is, but so I'm just on the lateral border of the pedicle. So I'm just going to medialize it a little. Do you have a mallet? I'm just going to tap it in. And then I'm going to advance this. X-ray. Okay, you can see the pedicle. I'm kind of in the midpoint of the pedicle right now. So can you go back to lateral? So to be absolutely safe, you should take a couple of shots, both in AP and lateral. So I know I'm in the midpoint of the pedicle on this AP view. And so one view is no view in a fluoroscopic image, right? So you need more than one view because it can be very misleading. So let's see how far I am into the pedicle. So I'm not into the pedicle at all. So that's actually not great. So what I'm going to do is pull it out a little bit and try to redirect it more medial. Okay, picture here. Okay, yeah, I'm just going to tap it in more medial. X-ray. Advance it. X-ray. Okay, that may be a little far, but let's take a picture. No, I mean AP, I'm sorry. Thank you, my mistake. So I did project the K-wire out a little bit more. I meant to, I'm looking at it now, it's 15 millimeters. It would have been better at like about 12 or so, but it should be okay. It shouldn't be dangerous even if I'm medial. But I'm actually not, so it'll be okay. So I can medialize this a little bit more even. I'm gonna pull it back actually a little bit, then medialize it, and then X-ray now. Okay, all right, great. Can we go to lateral? So I'm at the medial border of the pedicle right now, which is okay as long as I'm in the vertebral body posteriorly. Yeah, so I'm in the body posteriorly. So that's a safe pedicle placement. So I'm just going to advance the screw over the K-wire. X-ray. And X-ray. Okay. All right. So then I'm just going to unscrew it. Okay, we have our first pedicle screw in. See, not too big of a deal. We could do a second one. Okay. So there's a lot of resistance on the fascia here, which I don't actually like. You could undercut the fascia. It's not going to dehisce. It's actually not that disruptive either. And it'll facilitate raw passage later. So I would recommend doing that. And again, we're not cutting any of the muscle. I'm just cutting the fascia a little bit here. X-ray here. X-ray. X-ray. Okay. Can we get a AP? Can you give me a Ferguson view? Meaning 20 degrees this way. So this is straight AP, and I don't see the L5 pedicle at all. So we want a Ferguson view here, and we'll go AP here. Okay, good. So I am just a little bit too medial. I'm going to put myself lateral. X-ray. X-ray here. Yeah. X-ray. Okay. Just going to have to move it myself a little bit better here. X-ray. Okay. One more picture. I don't like that. X-ray here. X-ray. Okay. Can we go to the lateral now? I have plenty. So if you look at this view, I have plenty of room on the pedicle medially. So I have no concern there. I just want to make sure I'm not too high on the pedicle here. It looks like I'm high on this AP view, but it could be misleading. You can also see the cage. It just needs to expand more. The cage is in the midline, but we just need more expansion, and it would have filled that gap. So I'm actually very happy with the position of the cage. It's just the cage was too small to begin with. So that looks okay there. So like I said, it can be misleading on a fluoral sometimes, on the AP view about where you are. So here I know I got plenty of room, so I'm going to just advance this now. X-ray. And can we get an AP now? So that's the back part of the vertebral body. But I knew I had plenty of room here, so that should be safe. Thank you, perfect. So Ferguson view is really a view down the lumbosacral angle. And you can see I'm right in the middle of the pedicle of 5 there. So I'm just going to actually just advance it. Oh. I think this is stuck. What? Yeah, it won't let me. X-ray. Just won't let me. I don't know what happened to it, but there we go. This won't let me turn. Actually, it might be stuck for some reason. But let's go AP again. And can we go to lateral? I'm well in the midpoint of the pedicle, but this it's supposed to. It's a little stuck. I don't know what happened. We've been using this before, and maybe I don't know. The K-wire. Yeah, that's probably what happened. Meaning, like the K-wire is not down. Not a fair amount more. Yeah, so I'm already in a vertebral body, but I can't advance the K-wire. It's just stuck. Oh, there we go. Not really. It's stuck. Picture. Well, I'm not sure why I can't advance it. Okay, there we go. X-ray. Okay. Okay, feels like good fixation here. X-ray. And X-ray. All right. Okay, so, and can we get one more picture? So we could align the screws here, and we could pass a rod. Well, we don't have to pass a rod then. I guess we don't have a handle. Okay, so that's it for the MIS TLIF. If you could do the screw fixation on the other side. I'd be happy to answer any questions.
Yeah, very, very nice demonstration. Thank you. How do you, with the one-step Viper Prime, do you put them in afterwards, or how do you handle the sleeves? Because they would be in your way of your tube. And so do you put them in after, right, exactly the same way you did it right now, or do you put a K-wire in there? Or?
It's a great question, Christoph. I've gone from using completely flow-based K-wire, Jamshidi needle, to navigation, now robotics. And so the workflow, I think, differs depending on what you're trying to do. And if you're going to use Viper Prime, which is a one-step system, I think I would do it just the way I did it. I'd put the cage in first, then do all 4 screws. If you're using a different system, like the traditional system, what I used to do was just cannulate each of the pedicles, leave a K-wire, then splay the K-wires and put the tube here. So if you can picture 2 K-wires are coming out here, and then you put the tube in between. And so, but it's just surgeon preference. There's more than one way to do it. You know, some different systems have like headless screws, so you can put the screws down without the screw head or screw extenders, and then do your TLIF, and then attach the screw heads after the fact. So there's just different workflows. I think they all work. Anything? Okay, great. Thank you.
Thanks.